Well, hey guys, my name is Brandon Ayres. I'm from the Cornea Service at Wills Eye Hospital and Ophthalmic Partners of Pennsylvania, and I wanted to present a couple of cases from an ongoing research project that we're working on. This is doing cataract surgery in patients with known retinal pathology, and we're doing the surgery on the Zeiss Quaterra platform. These are my financial disclosures. Nothing will get in the way of the subject matter of this talk. Now, why do this study? Well, there's lots of different phaco platforms out there, and I think each one of them needs to be looked at and examined to make sure it's performing as it should. And I think the best way to test that is in patients who are a bit more challenging than average, and for me, those are the patients who already have some sort of retinal pathology. So the real purpose of our study is to look at the safety and efficacy and the efficiency of cataract surgery done with the Zeiss Quaterra in patients with known pre-existing retinal conditions. Now, there's a couple of endpoints that we wanted to look at. One is just simply the time of the phacoemulsification. How long does it take? Is the machine efficient? And that is different from the energy used during that phacoemulsification. We also want to see, of course, if there's any change in the pathology in the retina of these patients having surgery. Does in any way doing cataract surgery using the Zeiss Quaterra make their condition worse? I also wanted to see if the pathology was recognizable on the IOL master. There is an OCT function on the IOL Master 700. It is not meant to diagnose pathology, but can you recognize it to at least know you should get a full thickness or a full OCT on a patient after their biometry? And of course, we're going to measure any kind of complication and safety factors on the cataract surgery. So let's do this by walking through a couple of different cases. The first case is going to be an 82-year-old woman who came to us from her retina specialist, and she had a known history of macular degeneration and had received injections for that. Vision at baseline, best corrected, was 2200 in the right eye and 2400 in the left. Now, that is legally blind for this patient. These are the retinal photos, and you can see that retinal scar on the right side in the macula. The left eye, although the macula doesn't look to have a scar, there is some subretinal fluid there. That's difficult to see on just the color photo. Now, she also had a history of Fuchs endothelial dystrophy, and this is her cell count from the central cornea. And what you see here is very, very low cell counts, which are going to make this surgery even more challenging. But very doable. Now, this is the standard OCT, and with this you can see those subretinal changes. You can see the drusen. You may be able to see a little bit of fluid there. Not the easiest OCT to get because she did have significant lens changes, and that makes it a little bit harder to get a high-quality OCT. Now, when we compare the standard OCT, here the one done by Heidelberg on the Heidelberg machine, if we look at the little fixation OCT where you're supposed to catch the macula, you do see a little bit of pathology on both the right and left eye. So in a case like this, I do think that there's enough recognizable on the IOL Master OCT to at least warn a technician or warn a practitioner, hey, you might want to get a traditional OCT on this patient to make sure there's not significant pathology. So now that we have all the diagnostics under our belt, let's go to the operating room and see what this surgery looks like on the Zeiss Quaterra cataract platform. All right, so we're in the operating room, and this is just putting a little OVD into the eye. We want to protect this patient's endothelium. Remember, she has Fuchs dystrophy. We're going to do manual capsulorhexis, not using femtosecond lasers in this study, as it may alter the findings, and then hydrodissect. Now, you might be able to tell this lens is pretty dense. Now, this is the beginning of phacoemulsification. This would be time 1, when the phaco enters the eye, and then as the cataract comes out, from the time the phaco goes in to the time that last little piece of cataract comes out, which will be right about now, that will be the time of phacoemulsification. And now we'll just remove the cortical material. There was a little bit of zonular laxity in this case as the cataract was so dense, so after we refill the capsular bag with OVD, we're going to put a capsular tension ring in. This is more for safety rather than any real complication during the case. The lens will go in and then take all the OVD out, and that is basically cataract surgery in somebody with retinal pathology. So as you can see, that surgery was relatively efficient. The parameters in this case include an actual phacoemulsification time, not energy used, but phacoemulsification time of 4 minutes and 26 seconds, which is definitely on the longer side for me anyway, but not a long surgery by any means. No complications were encountered, and although this is fast forwarding, we did not see any progression of her AMD, and she did return to a best corrected vision of 20/30 on the right eye and 2400 on the left. The 2400 vision was because of the macular pathology, but we did get this patient back to day and nighttime driving vision by doing her cataract surgery. Now here are her post-surgery images. This is the retinal imaging, and here is the OCT on the right eye. You can just see, we'll just step through that macula. You can still see the drusen and some fluid. So she still is dealing with macular degeneration. And even with this distortion in the macula, she still maintains a vision of 20/30. And the left eye also has some macular pathology as we walk through the macular cube of the OCT. Although I didn't have high-quality images saved of the cataract, they were printed. I do have high-quality images of her corneas and lenses after the surgery, and what you can tell is there's nice clear media. The Fuchs endothelial dystrophy did not progress by doing the surgery, which means we were nice and safe for this patient. So case 2, we'll do this one a little bit quicker. The 69-year-old patient with a history of high myopia and macular scarring also from AMD, a vision of 2200 in the right and 2400 in the left. That's best corrected. Here you can see the macular scarring. Those little white bars, I'm sorry, just some digital artifact in our photos, but you can see the macular scarring on the right eye, less so on the left. Very difficult to get OCTs preoperative on this patient, but you can see that large scar on the right side. The left eye also has some irregularities. And if we compare the standard OCT with the OCT on our IOL master, I do think that you can see those elevations in the RPE. Again, recognizable pathology on the IOL master. This should trigger the practitioner to get a full OCT. Here are some of the preoperative images of the cataracts on the right and left eye. Now let's take a look at the surgical video. All right, so here we are again, and I think the first thing you'll notice is that the cataract looks much worse on the surgical video than it did in the slit lamp photos. Phacoemulsification unit is in, so again, this is time 1, and we'll keep timing until the cataract is gone. So there was the beginning, and here is the end. Of course, we fast forwarded through the case. Cortical material will come out. This all happens nice and safely, and unlike the last patient, we didn't have to worry about any zonulopathy. OVD is going to go in, and then we'll place our IOL in position, remove the OVD. So now that the surgery is finished, let's take a look at some of the parameters and see how this patient did. Here, a shorter phacoemulsification time, 1 minute and 58 seconds. Also no complications and no progression of the AMD in this patient. And we were able to recover a best corrected vision of 2100 in the left eye, again, where she had the large macular scar, and 20/20 in the left eye. Here are the post-cataract retinal images. Here's the picture of that right eye with that large submacular scar. The left eye was very difficult to image, so I don't have a high-quality OCT to show you, but there was no progression of the pathology. So in summary, cataract surgery done in patients with retinal pathology using the Quatera cataract system seems to be safe and efficient even in these patients who probably have overall worse cataracts than average and pathology pre-existing in the back of the eye. We've not seen any complications from the cataract surgery. So far, we've not seen any progression of retinal disease with an excellent safety profile. Now, as we continue the study, we'll be able to tabulate more data, and eventually this should come as a publication or a presentation at either one of the large meetings or in one of the commonly reviewed journals. Thank you so much for spending the last few minutes with me as we have reviewed these complex cases.
Okay, so now we're going to be talking about management of capsular rents in high-stakes settings using optic capture. So we're going to go through 2 scenarios here. One is a posterior capsular rent with a toric IOL. The other is a posterior capsular rent with retained lens material. All right, so we will walk through these and talk about how I got myself into that mess and how I got myself out of it. So this is a lady she's post-vitrectomy, history of an epiretinal membrane peel, opted for a toric IOL placement about 2.5 diopters with the corneal cylinder. Coming to the land, everything seemed just fine. At the end of the case, I'm going in. I always go in and take out the viscoelastic behind the lens because I don't want that postoperative rotation. And as I'm doing that, oh my gosh, what's happening there? I see a posterior capsular rent that has evolved behind the lens, happened just like that. And I think, her posterior capsule is probably pretty floppy, history of that vitrectomy. Somehow I must have snagged it with my IA when I was going under the lens and tore it. Now, unfortunately, this tear is right underneath where I need to put the haptic for my IOL. And that's going to be a problem because if I leave my IOL in the orientation it's supposed to be with this haptic right there, it's probably going to dislocate into the posterior segment, and that would be bad. But she does have a lot of corneal cylinder. I really don't want to leave her with that much cylinder. So I really want to try keeping this IOL in the eye. So what am I going to be doing? I'm thinking to myself, what am I going to be doing? And I remembered my training. This is actually a tip that I got from Dr. David Chang about reverse optic capture. And so you can see here, what I'm going to do is I'm actually going to leave the haptics because I never want to put those haptics in the sulcus of a one-piece IOL because that's going to give me UGG. But I'm going to leave those haptics in the bag and I'm going to prolapse the optic now above my capsular rhexis. And I'm going to use that capsular rhexis to hold the optic centered and stable. And if you look at this, you can see that if I had left that haptic here in that area, I certainly would not have had a stable IOL. But now I'm using the optic prolapsed anterior to the capsule to help support it and keep it stable. And the patient actually ends up doing great. She's got her toric IOL in the bag. One-piece lenses can never go in the ciliary sulcus. They have thick, square-edged haptics that are designed to fibrose into the capsular bag and prevent posterior capsular opacification, which they're really, really effective at doing. But if you leave those haptics in the ciliary sulcus, the movement of the iris over that lens will chafe the iris. You'll get pigment dispersion, cystoid macular edema, and continued, unhappy patients. And I see a lot of patients like that ultimately need exchanges. If this happens in a setting where you're really, really wanting to keep the IOL that you have in the eye, think of reverse optic capture. And again, of course, it requires a nicely round-centered capsular rhexis to be able to do that. Okay, so again, let's just look and see how I did that. What I did is I just reached across, pulled one side over the anterior capsule, and then pulled the other side over the anterior capsule to keep that centered. She's 20/30 at day 1, a little bit of edema, 20/25 at month 1, and is happy. History of ERM. Okay, let's go on to the big leads. Like what happens now when the worst of the worst happens? This is a patient that I was operating on, actually same day bilateral surgery, first eye, no problem, completely fine. Everything's looking good. I'm feeling great. I'm like, this is going to be done in no time. You're going to be seeing awesome. She's actually a fellow surgeon, so I'm really want to do my best for her. Second eye, I go to do a hydro dissection. Something a little funky happens there that I didn't pick up until I was reviewing the video afterwards. And you can see there's actually a lot of movement in the anterior vitreous, so I do that hydro dissection. Let's see what happens. So I go in to do my first chop. Yep, that's fine. Go to do my second chop. Seems like a little bit more mobility than I was expecting. I was like, what's going on here? It seems like a little bit more mobility, but I'm gonna ostrich a little bit. I'm gonna pretend like this is not actually happening. I'm moving that lens segment around. I'm like, it seems like a lot of mobility here. What's going on? A little unusual. I go in to pull that up and oh, bam. I actually have a very large posterior capsular rent. And then I'm gonna try and pull that other one up. And unfortunately, it just falls all the way through. So now I have dropped nearly this entire lens into the back of the eye. And you can see I have a long, pregnant pause here while I'm thinking about what to do. And you've got to remember, when you have a PC rent, the playbook is the same, no matter who you're operating on, no matter what you're doing. I'm going to put in a cohesive or a dispersive viscoelastic. I'm going to suture my main incision. And then I'm going to go ahead and do a vitrectomy. Unfortunately, actually, my retina colleague was right next door, so he is going to come over and do a posterior vitrectomy. After he's done with that, I'm going to go using that same retractor posteriorly because we've got the posterior axis, take out that residual cortical material. Really, really try and maintain that anterior capsular rhexis because I'm going to need that to hold my new lens. I'm going to enlarge my incision so I'm not burping stuff out of the eye with a lot of pressure. And I'm going to go ahead and put a sulcus lens in. She'd opted for a monofocal lens, and there's really no other option at this point, given the fact that the posterior capsule is completely blown out. And I'm going to go ahead and optic capture this because I want this lens to stay nice. I want it to stay centered. I don't want to have to rely upon the haptics or centration. And I want that predictable effective lens position. And there we go. Case is done. So in summary, with a posterior capsular lens in the bag or out of the bag, don't panic. You are in control. Some deep breaths. Optic capture is really your ally. So you really, wherever you are, posterior capsular rent, try and preserve that anterior capsulorhexis because that will give you the most stable, most predictable, effective lens position. If your lens is already in the bag or if you only have a small rent, you can have that option of doing reverse optic capture and centering a toric or potentially even a multifocal IOL. Breathe deeply and remember your training and that you've got this. So, thank you.